over to you.
So thanks very much, Jeremy, and good afternoon, everyone, and thanks for the invitation. Despite COVID really taking up all our time and focus, there have been other cases, and I've put together the ones that have come through over the last month or two, and everyone had a COVID test, I might tell you, but none of them turned out to be COVID, so that's the first clue. So please place your comments in the chat, and let's make it interactive, and Jeremy will follow up and pass on to me. So this is a slide I always begin with. Remember, the most important thing in any case is history. We're all thinking COVID now. And if you get an acute febrile illness, please ask about where do they live? Where have they been in the last few months? So know your geography. It's not okay just to say the DRC or Guinea. Remember, we're having Ebola in both now, so we really need more detailed histories. What is the occupation or hobbies? And be very wary of healthcare workers and those who have an occupational health risk that poses a risk for exposure to animals or insects, so vets, abattoir workers, farmers, exposures, insects, plants, unusual food, or sometimes not so unusual like we had last time. What's happening in that area and what are the usual endemic diseases? Are there any drugs that the patient's on? What vaccinations have they had? Anything about their immune status? Are there any telling dermatological lesions that might put you in the right direction? And then, what are the syndromes that you're looking at clinically? Any pertinent signs? And then very, very important, what are the basic bloods? White cell count, differential, platelet count, and it needs to be the absolute count, not its normal. 152,000 in a patient who's unwell and a farmer is something that always worries me because it may be on the way down. Liver functions, particularly AST and ALT, are always helpful. And then let's never forget malaria in this country. Can pop up anywhere, even the crew. And then make sure that the pieces fit. What is the epidemiology? Who is this person? What have they been exposed to? Where have they been? What are the clinical features? And what are the laboratory findings? And if any of those don't fit, you need to rethink your diagnosis. Someone who's never left a home for the aged in Johannesburg and is now bleeding is not going to have Congo fever. So make sure you get good histories and put the pieces together. Okay, so let's look at the first case. And we're going to be traveling all over the continent. And we're going to the beautiful province of Limpopo. These are the hills of Venda. And the patient address unknown, but frequents these hills and presented to the veterinary nurse in Louis Tricard. So the farmer complained that the goat couldn't swallow. And just be very careful when you hear that it's not rabies. That commonly presents with esophageal spasm. But in fact, they intubated the patient and they noticed edema of the tongue and some sort of hard swelling at the back of the tongue. Everything went well, and like with many things in veterinary medicine, patient got antibiotics and steroids. I don't know that they did a biopsy. And actually responded very well and went off back to the hills. The nurse, on the other hand, was scratched. I'm not sure if it was the mouth from a tooth or from the paws. I think it was while they were intubating, she got a scratch. And she was a bit concerned, and like many veterinary practitioners, she reached for doxycycline. And in many cases that kind of works. There are many zoonotic diseases that respond to doxycycline. She actually developed a lesion over the following few days, and they started clindamycin. So there is the lesion on her finger. On the other finger, you can see some little nodules. This was not painful, but it was quite itchy. So she got a week of clindamycin. She didn't get better. And then she came back and they gave her a different course of therapy. and they phoned us. So what do you think? So veterinary nurse, vendor, goat that's recovered now on this lesion. Any offers?
We've got two people saying off, 3 people.
Okay, that's quite a good suggestion. Anything else? From anybody?
So, Lucille, do you want to give, for those who are not around, the sort of one line of off?
Yes, we'll come back to it.
Okay,
so off is parapox, and it's not uncommon in goats. Just remember, this goat didn't have any lesions on the mouth that we know of, besides that swollen tongue and the swelling at the back of the tongue. So we'll come back to that. So she was put onto, when she came back, she was put onto augmentin. She developed this rash. And if you look at it very clearly, you'll think at the beginning that this is maybe a staphylococcus rash, or there's there's a bit of folliculitis there. But if you look a little more carefully, it looks vesicular. So now what? So now she's put on augmentin for maybe staph, and she's put on some steroids in case this is a drug reaction to the clindamycin. It's all a bit itchy, but it doesn't get better. So now we, already 4 weeks after the initial event, the goat is well, and she's got this rash, both arms. Any change in your diagnosis? What do you want to do?
We've got a suggestion of zoster in the chat.
Okay. All right. Do you think the goat has got something to do with that? Okay, so anybody else? That's the original lesion. This is the progression now, and
scabies.
We decided, yeah.
Scabies from someone, and then Nosisa is saying Corynebacterium. And Nosisa, which Corynebacterium? Or any of the species?
Okay, well, I think those are all good suggestions. She doesn't have a medical aid, and there's not a lot of options for doing any further investigations in Louis Trichardt. So we asked for, this is actually what we had first. So we asked for a kind of biopsy or a piece of that lesion to be sent to us in just a bottle of a universal container for various laboratories here, and also to include electron microscopy. So I think for us, the differential, I think number one is off. So this is off, it's parapox. This, you can see 2 previous patients. They both had single lesions on their fingers. The one was a goat farmer in Prince Albert that I showed previously. The cross on that lesion is an attempt at some self-treatment, and the redness is from further treatment. It's self-treatment, that's a bit of oil. But we did get a specimen from her, and it showed pox, parapox. The one on the top right is again a farmer in Randfontein, closer to us, and again it showed ORF. So ORF is it's quite a common disease in sheep and goats, but they generally have lesions, and they have lesions particularly on their mouth, which leads to some difficulty in feeding. And so feeding becomes a major issue. So I think ORF is still very high on the list, and it's common. Other things that were considered, somebody mentioned herpes zoster. If it's related to the goat, herpes simplex or herpes zoster, or whatever herpes, tend not to jump species. So they're very species specific. So they're not zoonotic, and that would be very unusual. I did speak to the vets this morning. Foot and mouth, the common one that you have, also is not generally a zoonotic disease. Vesicular stomatitis in livestock generally doesn't jump species. It's very species specific. when you think about animal diseases, you must think about the normal flora in the mouth, and then you must think about what they eat and what they pick up. So if you have a carnivore or a crocodile or something, or a snake or something, it's the animal's own flora. If it's a carnivore and it wouldn't apply to livestock, it would be what they ate for their last meal. And then there's also environmental things. So fungal infections, I think, are important. And sporotrichosis, I think, needs to be considered. And that was one of the differentials initially when we saw these little nodules. So the specimen will come up for fungals. I think mycobacteria was also considered, the non-tuberculous ones, and animals get a whole lot of different ones. And then we will do electron microscopy to see if we can see the lesion on microscopy. So Monica is eagerly awaiting the specimen. We only got the consult late on Thursday, and as soon as I have some results, I will share them with you. So if it is off, you don't do anything, they get better. And the patient on the left had multiple courses of antibiotics. The differential diagnosis ranged from staph to anthrax. Her sister-in-law, who's a doctor in England, said, "Oh, you must rush to the hospital and get anthrax treatment with intravenous antibiotics." But in fact, in Prince Albert, they don't have any anthrax. So, that really didn't fit. It's usually very swollen, not painful, doesn't quite look like that. So you do get anthrax in Limpopo in the Kruger National Park. And about 5 years ago, it kind of moved towards the border of the Kruger National Park. But we've not had it outside the Kruger. And it really doesn't look like her lesion. It's much more swollen. And, I don't think that's part of the differential. So the one on the left, I actually told her to RHT out of hospital before they did surgery on her and gave her more antibiotics. And being a farmer and quite a strong patient, she went home and it got better. Similarly, the one on the top right. So I think we'll await the electron microscopy and any fungal cultures. And in the interim, I think stay away from any major treatment. So watch the space and I will let you know, life is never dull. But no response to antibiotics and no response to the steroids that were given for a query drug reaction. Okay, let's move on. So let's go to the Kruger National Park. This is a picture taken last week from Skakuza. And over the Lower Sabi River, you can see the new Salati Hotel, which is a train carriage that's been converted into a luxury hotel. And in fact, the patient is the hospitality manager there. And obviously lives in an area where there's a lot of visits into the bush. But her job is not directly with animals, but people who resident in Skakuza, have many opportunities to enjoy some bush leisure time. So she presented with a headache and a fever and some myalgia, previously well, and that's the lesion on the back of her foot. Any comments? Anything you want to ask? Must remember, bloods are not that easy for many of these patients. So there's often just, what do you think it's likely, what fits, and how should one treat this?
So we've got one person asking about the platelet count, and then Nosisa suggesting rickettsial disease. So presumably tick bite fever.
I don't have a full blood count. I know it was subsequently done when she got a little bit worse, but it was essentially normal even then. So headache, I think that it was low-grade fever, myalgia. There'd been a lot of COVID on the train, don't tell the tourists. And there was a concern about COVID with the headache and the low-grade fever and the muscle aches, no real respiratory symptoms. And of course, she had a COVID test, which was negative.
got a few people suggesting tick bite fever or rickettsial disease.
Yeah, yes. Okay, so, tick bite's very common in the park. It doesn't look absolutely typical. It's got quite a lot of erythematous discoloration around the lesion. And in fact, she did get a course of doxycycline and she didn't get better. She actually got worse. Whoops. Oh gosh, what did I do? There we go. Am I still screen sharing?
Yeah, it looks great. Yeah.
Okay. So the lesions, she got more lesions, some on her palms, some on her arms, some on her hands. And you can see they're quite itchy. They're not painful. A little bit of swelling and quite widely distributed. So she did have a blood count, and not easy to get a biopsy or lots of investigations. But this is not tick bite fever. And in fact, when we went back to that lesion on the back of her ankle, it seemed to be more traumatic from her sandals. And yeah, I think it wasn't typically tick bite fever for the reasons I've mentioned. And we'll show you some typical ones just now. So this was very widespread.
So we've got some suggestions. So perhaps about the previous lesion, about a venomous insect of some sort. And then Jessica suggests some sort of urticarial reaction or allergy. Lauren suggesting some drug reaction.
Yeah. Okay. So I think if you look carefully at some of the lesions, these are cell phone pictures. There's some more. They're not that easy well, those are perhaps a bit better. The ones on the left looked a bit like COVID fingers with chilblains that, may or may not be. But if you look at some of the lesions, perhaps you could imagine that they're target lesions. So, drug reaction, erythema multiforme as a cause of the whole problem rather than a tick bite, which I think it absolutely wasn't, looking back. So we decided in consultation with the dermatologist, never had a biopsy. It's just really difficult to get specimens out, and COVID was an issue at that stage. So we put her onto steroids, 40 milligrams, and a whole lot of antihistamines. And it really didn't touch her, nothing. So then we went back, and her weight is close to 100 kilos. So we just increased gave her, I think, a Solumedrol drip, pushed a few more antihistamines into her, and increased the steroids to 60 milligrams, prednisone a day. And she responded beautifully. So I think the working diagnosis is probably an erythema multiforme. And if you go back to some of the lesions, perhaps there's, you can get the impression that some of them are target lesions, particularly on her hands on the right. So I think that's the most likely diagnosis. Yeah, I think and she did respond rather beautifully. So as many things respond. So drug reaction, but I don't think that original lesion was anything other than, I think, a traumatic lesion. But if you see around it, I think that is real. So I think erythema multiforme, from whatever cause, difficult to say. She didn't have the usual drugs. She had doxycycline, nothing else that should precipitate, and a mild febrile illness. So not COVID, and yeah, always interesting, something interesting from the Kruger National Park. Okay, so let's go to the Karoo now, and we are going to Hartswater, and Hartswater is about 180 kilometers north of Kimberley. It's a farming area, and always some interesting things on farms. This is a farmer. He's 54-year-old. He presented with fever and myalgia at the GP, had a slight blue mark on his torso. Doctor was correctly concerned about rickettsia, treated him with doxycycline. He seemed to improve a little bit. And then over the course of the week, he just got worse. Of course, he had a COVID test. It was repeated. It was still negative. He got worse, and he was referred to Kimberley with a depressed level of consciousness. And in fact, when he arrived there, he was not very responsive. He was tachypneic, and there was no bleeding. So any thoughts here? What would you like? What are you thinking of? You know, this is what you get. This is what you get on the phone. This is what you get to deal with. I never had a picture of the blue mark, so I can't share it with you. Anything, what would you like?
We've Marianne suggesting perhaps Crimean Congo.
Okay, you always have to consider Crimean Congo. It's endemic in the Northern Cape. And when you hear something that's in a farmer, acute febrile illness with myalgia, and not really responsive to doxycycline, absolutely need to consider Congo. They may get CNS problems, and in fact, quite a few of them present with confusion. And then you get some nonsense history that just leads you astray. So be very, very careful, but it's not uncommon to get CNS. Anything else?
We've got some,
what would you like?
Some votes for Rift Valley fever.
Okay, so I'm glad you've mentioned that. We are worried about Rift Valley fever this year. It's 10, 11 years since the last outbreak in the Northern Cape, Eastern Cape, and some other areas of the country. There have been very good rains. I wouldn't say there's been a major drought in all the areas, but there have been excellent rains. So Rift Valley fever absolutely has to be considered in any farmer, abattoir worker or vet who comes from an endemic area or who's had contact with livestock. And encephalitis is a very important complication in a small number of patients. DIC, hepatitis with really horrendous liver functions, ophthalmic complications, retinitis, which is a much later complication, and encephalitis are very important. So you must be thinking Rift Valley fever now. So we haven't had any alerts from the vets. One would see abortions in livestock, which would prompt an investigation for Rift Valley fever. They would hopefully call us. We do have a close liaison, and that's how we knew about the 2010 outbreak. That would really prompt Rift Valley fever, but we are starting to test for it in patients coming from that area. Okay, so what would you like?
Got a vote for malaria, 2 votes for malaria as well.
Okay, so always look for malaria. I don't think in this country you have an excuse not to look for it. But I think Congo fever, tick bite fever, Rift Valley fever, and don't forget arboviruses. West Nile is endemic, and you can get the acute febrile illness with a maculopapular rash, and then occasionally you get an encephalitis. And just to mention that there have been a number of cases of West Nile in horses in Gauteng. So it's been around Kyalami, it's been around Sunninghill. So just remember that if you see a patient from there, just think West Nile. There's been a lot of rain, and I think arboviruses anywhere need to be considered. Okay, so do you want some bloods? So this is what was done. Rickettsia, this is from the pathologist, and this is some of the consideration. Patient was started, of course, on steroids, some Clexane, some Invans, and then changed to ceftriaxone and doxy. I don't think any farmer should not have the benefit of either ciprofloxacin if they're very ill or doxycycline. You may not find the SCAR. Very ill patients are quite hard to examine, and they're not examined properly, as you will see just now. And I think they always need to get the benefit. And certainly tick bite fever can present with an encephalitis. So they did blood cultures, they did a rickettsial PCR, they did some hepatitis studies, and they investigated for some the neurological side of things. Of course, they thought about COVID, stroke, COVID neurological complications, stroke, viral encephalitis, and of course, Congo. So here are some results. What do you think now? Do you want to comment? Sorry about the spelling mistake. I copied it straight from the email. Anybody want to comment? Now, what do you think?
You've highlighted a lot in yellow, but
yes, I know.
You've got a lot of experience, but I mean, so would the diff count surprise you, that diff count, or not really?
So generally, the white cell counts can be anything in Congo. They're generally leukopenic. They may have I think the neutrophil lymphocyte is not hard and fast. I think a neutrophilia would generally suggest a bacterial infection. And there are many in this group. Don't forget Q fever, which is not uncommon in farmers. So, there is a differential, as well as, the salmonellas, the tick bites. What did worry me was the thrombocytopenia. And generally in patients with Congo who are pretty ill, the platelets are low. So 22,000 fits very well with Congo, but he wasn't bleeding. And Congos bleed. They invariably bleed. You have the ones in the Crimean area, which are much milder, but our Congos, by the time they get to hospital, they're non-encephalopathic and have platelets of 22,000, they bleed, and he didn't. The Congos with a worse outcome tend to have higher white cell counts. So it's not impossible, but that platelet count certainly, it just doesn't, it stands out for Congo, but why is he not bleeding? Had a little bit of renal dysfunction. The ALT, AST are completely in keeping with Congo, but they could be in keeping with tick bite fever, Q fever would also fit, and I guess a number of other unusual bacteria. CRP is neither here nor there. PCT is neither here nor there in Congo. So he had a lumbar puncture. He had a CAT scan. CAT scan was normal, and you can see he's got an increase in neutrophils, increase in lymphocytes, and in fact the protein was up, and a couple of red cells. They did an extensive workup for viral encephalitides, but there was nothing. Just always remember herpes, hepatitis as a differential, but these in our multi-organ, rapidly progressive, they even occur in farmers, they have no skin lesions, but those liver functions would be enormously high. So that doesn't fit. So I think they went back to what was the obvious sign. There was this bluish mark. I think it was not very impressive. They gave him IV ciprofloxacin. In fact, he required, I think, some respiratory support. And they gave him IV Cipro, they gave him oral doxycycline, and they sent off rickettsial PCR. So generally, rickettsial PCR, as you will hear, is not that sensitive, and it's best taken from the lesion. But if you get a nice eSCAR, you've got the diagnosis anyway. And he slowly got better. He woke up, his platelet count went up, and his rickettsial PCR surprisingly came back positive. So he was a case of tick bite fever. And, I think, note what you see. I think that blue mark, which they failed to send a picture of, was highly suggestive of an eSCAR. And I think he fits very well with tick bite fever, and it was confirmed by the PCR. So he's now been discharged, and he's done very well. And encephalopathy is not uncommon in tick bite fever. And patients can be very ill, and you think farmers have all had tick bite fever when they're young, and then they get mild disease, especially if it's Africa. But it's our most important differential for this multi-system Congo fever-like illness. Okay, so now we're going to go to Richie. So just a little bit closer to Kimberley. Richie, not quite, this is what it looks like. It's on the road. You can go to Loxton, which is another place we get lots of congos from. Not lots, but some. And it's about 40 kilometers from Kimberley on the banks of the Rit River. Big farming area, not quite sparsely populated, about 15,000 people, but it's a farming area. So he was admitted to the Rit private hospital, transferred to the Kimberley hospital. He had hematemesis. He had a gastroscopy, which I think they were quite brave to do. They should have thought about Congo before they did it. But the doctor who saw him has had lots of experience of Congo. I think he might have even had it himself. And he said, no, I don't think this is Congo. Anyway, the patient was transferred. He was hallucinating. He was seeing all sorts of wonderful images, and it looked very much like DTs. So we thought perhaps he likes to have a little alcohol on his farm in Richie, and maybe all this is kind of alcohol related. He was noted to have a rash, and we got the request for West Nile because of the rash and maybe an encephalitis, and because, this is the year to get West Nile. So there's the rash. It's quite florid. There was some on the soles, but nothing on the palms. And I said to the doctor, have you examined him, the consultant? He said, no, but I'm going to go and have a look for myself. So this patient was really ill. He was admitted to high care. And I think, there are some limitations to examination, as I mentioned. This is these are his results. Platelets are not really that low. They did drop. White cells were pretty normal. There was a neutrophilia, and he had some renal failure, and he had a transaminitis. So Congos can get rashes. They can get petechial rashes. They can get a morbilliform rash. This rash is not absolutely typical of Congo. This could be West Nile. Rift, you don't tend to get a rash, but who knows what drugs people have had. Q fever, you don't tend to get a rash. But there are other diseases you get rashes. So here it is. The doctor went to have a very good look. This is on his back. So I think it's a lesson and a reminder to everybody. Put the pieces together. The rash is very typical of tick bite, but West Nile could look like this. And don't take other people's word for it, and examine for yourself and look on the back, look behind the knees, look between the toes, look on the head, and look on all those funny places where patients who are really ill may not get examined. So once we saw this is very typical of tick bite fever. Really just went on with his tick bite fever treatment, and we didn't in fact even do Congo fever. I think this is pathognomonic, and he got better. And I think if you look at those results, I think the platelets were a little out of keeping. Renal function, could be Congo. Livers could be Congo. White cells can absolutely be Congo, but there is a differential diagnosis. So those are some SCARs of tick bite fever. Pictures on the top right are Jeremy's patient. You see the typical maculopapular rash. The bottom right is patient with severe tick bite fever and petechial rash. Just remember that serology is not very helpful in the acute stage of the illness. The fluorescent antibodies, it's an indirect fluorescent test, become positive only 7 to 10 days after the onset. You may get a positive PCR, look at the previous patient, but really it's a clinical diagnosis, and you really need to go in search of that SCAR. So doxycycline is the treatment of choice. If you need to give intravenous, IV ciprofloxacin, even in pregnant women and young children, please do not ask for a TMX. We've had a couple of those lately where tick bite has been pushed aside because the TMX, while Felix was done, and some doctors insist on it, and labs shouldn't do it, but it leads people astray. And tick bites, we have deaths every now and again from it. We might hear a little bit more shortly about other treatments for rickettsial infections, some of the newer drugs like tigecycline. Maybe John wants to mention something, but really very, very little work, but can be a severe illness and need to treat. Pregnant women, young children, please start with doxycycline. And after 48 hours, they should be better. If they're not, it may not be tick bite. But then you can, if they are better, you can change to anything else that you want. The macrolides are not that good. And I think they really need the benefit of the doxy or Cipro. Those are the lesions of Congo fever. Those are hyalomatics. This was a patient I showed previously. He got bitten on a farm in the Free State, multiple bites. He knew Congo, he knew the ticks, he knew what to do, but you can see they're not escars. And often there's hardly a mark. So, if you don't see a mark anywhere, or you see those little red dots, it's much more in keeping with Congo fever. Non-response to doxycycline, I think, is quite helpful. But just remember, doxy's got some sort of anti-inflammatory effect sometimes, and you might be led astray. So this is the kind of scoring system that's used for Congo fever. I think it really reminds you of the history that you need to ask, and you can give points to it. The clinical features: sudden onset, headache, myalgia, fever, and 3 days later they bleed. And virtually all our Congo fevers bleed. And they may have hematemesis, which leads people astray. It leads them to the surgeons with gastroscopies and sometimes terrible outcomes with nosocomial infections. So anybody with a hematemesis, please ask what is their job. About 15 years ago, or maybe 20 years ago, we had a patient in Johannesburg who presented to Helen Joseph with hematemesis. They asked about travel. He said, no, I never left Johannesburg. They did the gastroscopy. They found really nothing. And then they did the blood count and noticed very low platelets. And suddenly, like, what is this? And in fact, he was a Congo fever. He hadn't traveled, but he was an abattoir worker in Johannesburg. And animals come from all over. They get sold on the street in Soweto. You can buy them on the side of the road. And I was offered some Namibian sheep for 800 Rand. And, they may be viremic and they're not ill at all. So please ask, what is your job, and did you partake in any slaughter? And then you assign points, and then you assign points to the laboratory results. Unfortunately, in some places, you don't get a PTT. For the rest, you should probably get a result. And then if it's 12 or more, you must test for Congo. We are very willing to always test if there's any uncertainty. We need to reassure nurses, doctors, and family that this is not Congo, to ensure that the patient is well cared for and people are not afraid. I think with Ebola, in 2 outbreaks in Africa, I think we do need to, we do need to think VHFs, but look carefully at the history. And if there's any concern, we will always help out. But think tick bite, think Q fever, think others, think meningococcal, moving into that season, 2 or 3 months, looking at the specific history of very rapid progression. So history, jobs, etc. I think we've discussed that. Let's move somewhere else now. So now we are going to Uganda. And I have a case from Tabi Kralin, who is an infectious disease specialist in Cape Town. And he was asked by a GP about an American lady. She's an American national. She's living in South Africa. She has hypercholesterolemia, insulin resistance. Not sure what that really means. She went on this dream trip to Uganda, mountainous area. She went to the gorillas in Burundi, Impenetrable. And this is, I think this is maybe Burundi, but I think it's high up in the mountains. She also went to the Kabali forest, where she was trekking chimpanzees. So So that was on the 2nd of the 2nd that she went to see the gorillas. She developed sores and bites over her shoulder, her arm, and the upper thigh area while on the trip. She had 6 bites in total. When she got back to Cape Town, she was seen by the GP, diagnosed as an insect bite with secondary bacterial infection. She was otherwise clinically well. She had a bit of cellulitis. She got, around the lesions, she got a 10-day course of Augmentin. What do you think? What's your thoughts? So no systemic illness, and really just these 6 lesions that looked like indurated boils with an inflammatory halo. I'm reading straight from the GP's description. It didn't respond really to Augmentin. Anybody want to?
This was asking if we have a picture of the lesions or not yet.
So the picture, it looks a little bit like on the right, and this popped out on the left. And here are some more lesions, but now I've given away the diagnosis, but it doesn't matter. So these are some from various parts of the country, and we've had a lot of rain. We may expect some more of these. Previously, you can see these, they look like purulent papules or a bit of redness around, and then they have this sort of black dot in the middle, which is, I think, almost a giveaway, but sometimes they're much smaller. And then if you put a little bit of Vaseline on, and this is what she brought to, I think she dug a little bit into the lesions, to be honest. This is what popped out. So this is Larvae of Timberfly. The question from the doctor was this Timberfly or was this screwworms? So what do you think?
Got silence from here, but geographically, only one of them fits, right? In terms of where they're distributed.
Yes. And also screwworms invade wounds or open sores. And I don't think she had that before. So it started off with this papule. And those are, I think, fairly typical of Timberflies. They lay their eggs on clothing that's a little bit sweaty and perhaps, yeah, they like the smell of sweat. And then when you put the clothes back on, the eggs hatch, and the little larvae burrow into and then they burrow into the skin, and you get these lesions, and yeah, Bob's your uncle. So treatment is very easy. It's Vaseline, and then you suffocate these things. Don't go digging around. You just introduce infection, put a nice layer of Vaseline on, and the lesion on the right, and in fact, I have a little video, which I can share with you another time. It's from the Kruger National Park. And Julia, who's the wonderful GP there, I think has got to recognize these tumbus. They see quite a lot. And then she puts a lot of Vaseline on, and then she takes little videos, and out pop the tumbu larvae. Really quite satisfying. So there you go. Not uncommon. A great trip, and I think she's quite well now. So this was another great trip, and Jeremy was involved in that, and I'm almost done. This was COVID related. We had 2 expeditions to Antarctica to assist with COVID support. This is a South African mission who went on the SA Agulhas, and this is the emergency medicine doctor who accompanied the mission. There's, I don't know, about 24 or 30 people who had to be kept COVID-free prior to their trip. The ship takes quite some days to get there. And there'd been outbreaks of COVID at one of the country stations in Antarctica. So we put them into isolation, into quarantine. And unfortunately, I think there was a little bit of break in quarantine. And on retesting them just before they went, a couple of them tested COVID positive, although they were asymptomatic. So the voyage was delayed, but eventually they got there. And then the second, and they seemed to be well. They're otherwise quite a fit group, although I think one or two of them had some comorbidities. And then the second group was organized by the aquarium, where they had a competition, and 8 young people from all over South Africa were going on a much shorter trip to Antarctica on a andropov, so they were flying there. And again, we had to keep them COVID free, but they were so motivated. And there were limited funds to put them into quarantine in Cape Town. So they were put into quarantine in their hometowns. And I think they were really very compliant. They didn't want to miss out on going. They then went to Cape Town, were tested, were negative, had a week's quarantine in a very nice hotel, and then went on the flight to Antarctica, and then had a wonderful 2 weeks there, COVID-free, and came back. So the world of infectious diseases is always interesting, and you never know what's going to come your way. So over to John now for just a brief presentation. Thanks very much, John.
Okay, so I'll start with the stories. So this involved 2 twins, 4-year-olds twins, who became ill on January the 7th, or round about there. They were tested for COVID. Their mother also became ill around the same time, but all the testing was negative. The clinical condition of particularly the twins got quite serious quite rapidly, and some form of serious sepsis was diagnosed, or was suspected. And in particular, because they had profound thrombocytopenia. So I should say at this stage, they were completely well beforehand. They had, in terms of travel, they had been to a well-known resort in the Northwest Province, adjacent to a game reserve. Before Christmas, they had left that and returned to Pretoria around the end of January, and then got ill about a week into January. So I do have the investigations here. Let me just read some of these out to you. So by this stage, around the 13th and 14th of January, when they were ill enough to warrant admission, the twins' hemoglobins were 7 and 8.5 respectively. At that stage, the mom hemoglobin was 12.3. White cells 9.4 in the one twin, 7.6 in the other twin, 5.8 in the mom. Platelets 10 in the one twin, 50 in the other, 44 in the mom. CRPs 211 in one twin, 244 in another. The AL, let's look at the liver functions. ALT 62 one twin, 82 in another, in the other, 146 in the mother. The AST 274 and 240 in the twins, and 113 in the mother. The one twin had a bilirubin of 99. The other had a bilirubin of 47. The mom's was normal. So what do you think? Any other investigations you would like to do at this point? So they had blood cultures, nothing turned up positive there. And really, I think the doctor was really at her wit's end, trying to think about what this could possibly be in two little girls and their mother. So I haven't been looking at the chat. I don't know if anyone suggested anything.
A couple of people have suggested malaria, John.
And they would be quite right in suspecting that, because all three of them had malaria. And the parasitemia, sorry, let me just get the figure here. 18% parasitemia in the one twin. Don't have the figure for the other. And the mother's parasitemia was around about 2, which really fitted with the severe disease in the kids. The mother wasn't that sick, but sick enough to warrant admission. So they all were admitted and got artesunate, and all made a good recovery. But I think it really was, they were really desperately worried about the little girls at the time of the diagnosis was made.
Yeah, so they thought it was going to be a misc because of the absence of travel. And so malaria was not considered, and it was a chance finding on the full blood count. And there was thrombocytopenia quite marked. I think one was 20 and 24,000. But it was a finding by the lab that really confirmed the diagnosis because of the absence of travel.
Yeah. So we, as always with these cases, we did an investigation. They lived in a nice suburb in one of the North Cliff extensions. Not really any obvious risk transmission scenarios which we often see, although they were about 1 kilometer from the N1 highway, but so fairly close to that, but certainly not right on the highway. Their father worked in Benoni in a catering equipment supply business, and none of the rest of the family had done any significant traveling. So in terms of exposure, well, Northwest, or the place they went to in the Northwest is not a usual malaria transmission area, but it's possible that it's feasible that another visitor from a malaria endemic area had brought a mosquito in, and it may have come home with them from there. But as usual, the source of the actual mosquito, and we think there was only one mosquito. I'll tell you why in a moment. But the source of the mosquito was, as usual, as often the case, unclear. So with these 3 cases, we managed to get blood samples from the laboratory, and we genotyped the malaria parasites, and they were all identical on the 2 markers that we did, which are called MSP1 and MSP2. And this would indicate that it was the same parasite strain, and therefore almost entirely certain that it was the same mosquito. So this is Lucille sharing here pictures from our investigation. On the left-hand side, you can see the Gauteng district, I think the district environmental health practitioners who always take an interest in these cases. On our right, the lady on the right is our entomologist, Eunice, and the guy in the middle is the grandfather of the little girls and the father of the mom. And we always investigate these cases not because we think it's likely we'll find the responsible mosquito, but we want to check that there isn't any local breeding of mosquitoes, because once a female mosquito has fed, she needs to lay eggs and reproduce, or she wants to lay eggs. And so we have a look around for any evidence of local breeding. So although the vectors are not endemic here, in summertime they certainly can set up shop for a while and potentially produce a source of vectors, which, if there are gametocide carriers around, could result in a localized outbreak. So I'll leave it at that. But fortunately, a lucky positive outcome here. But of course, the mortality rate from this sort of malaria is about 10 times higher than the national malaria mortality rate, simply because these cases are often missed or the diagnosis is delayed.
Yeah. So thanks, John. I think just an important message: any unexplained fever, any progressive illness with depressed level of consciousness, jaundice, please just think malaria, especially if the platelet count is low. It's so easy to do a malaria smear, and it's the time of the year where we see these Odyssean or taxi malarias, and they're tragic to miss. So just think malaria. And I think just a message for COVID and malaria season. It's malaria season now. And don't forget, and we've had a few webinars where we've discussed missing malaria and misdiagnosis. Any acute febrile illness in a traveler, resident in a malaria area, you must do a malaria test. Don't first do the COVID, find it's negative, and then do the malaria. It needs to be the other way around. And in patients with ARDS, ask about travel. If they're resident in a malaria area or they've traveled to a malaria area, please do malaria. ARDS of malaria, ARDS of COVID, very often misdiagnosed with tragic outcomes. I think that's it, Jeremy. Thanks very much.
Thank you so much, Lucille, and John as well. That is, as usual, absolutely incredible. And apologies to those who couldn't get in. I know that I'm talking to those who did get in, but we're recording this and we'll put it on, we'll provide a link for it a bit later. Lucille or John, there's always a fascinating thing about the Odyssean malaria. I mean, how far can a mosquito go? How far from the N1 are you safe?
So they're weak, feeble flyers, but if they take hops, they can travel maybe a kilometer or two before they get swatted, eaten, or
Dumped on.
Oh yes. So generally, they don't go very far from where they originate, but of course, they can be carried in the wind. And in fact, they found mosquitoes at stratospheric heights and swept up in wind. So if they if it's a windy day, they could travel much further than they would normally be able to fly by themselves.
Yeah. Then the last comment on malaria. Travel is opening up in Africa, and malaria remains the most common cause of acute febrile illness in travelers. It's not Ebola, unless they're healthcare workers, unless they've had direct contact with patients. And for most people working or traveling in Africa, that is not the case. So please don't label them as Ebola and lock them up in a room till you get an Ebola test. Please test for malaria. Don't miss it. Thanks, Jeremy. I think we're done.
Thank you very much.